Now, the next speaker, Dr. Victor Castro, critical care specialist USA, is talk about ventilatory support for COVID-19 patients. Welcome, Dr. Hector.
Welcome. Thank you very much. Thank you very much for inviting me.
You can start now.
Okay, thank you. I am very happy to participate in this very important meeting, and I thank both Dr. Al Tamimi from the Ministry of Health of Iraq, and also Dr. Hussein, the president of the Iraqi Medical Association, also you, Dr. Yosef, for making it possible for me to participate, and also it's been a very informative presentation. Today, what I would like to do is go over the COVID-19 ventilator management and lung damage. Obviously, we all know that the primary organ that's affected by the COVID virus 19 is primarily the upper mucosa, nasopharynx, and then works its way down into the lungs itself, and then ultimately causing severe lung damage. And as we all know, that when it comes to COVID virus, like any other virus that causes pulmonary issues or pulmonary problems, we do know that we do have a situation where the primary affected part of the lung is actually the alveolar membrane and all the associated cells, specifically the type 1 pneumocytes. This is where we see the primary affectation. Now, we all know that coronavirus 19 causes ARDS. That is the main clinical thing that we see. But the reality is, as we all know, when we look at ARDS, which is adult respiratory distress syndrome, it's actually a cytokine surge that is affecting all the organs of the body, and not just the lungs. But because the lungs are so important for respiration and for other aspects of health, we have to be very mindful that it is going to be the primary organ affected, because that's where the virus primarily goes, as we see here, and with the pneumocytes, because as Dr. Altai mentioned of the ACE2 receptors present, and different from regular bronchopneumonias, which is the main lower airways that are affected, we are looking at the terminal airways. And when we look at how Corona-19 kills, it kills primarily by, as we said, affecting the lung and primarily the lung function. And that main function is the capacity of the lung to absorb, to inspire oxygen. And the main clinical manifestation is shortness of breath and ultimately hypoxemia, which can lead the patient to ultimate death. All of this being because of the severe inflammation that occurs at the level of the alveolar membrane, and the patient develops what we say is an alveolar block. I created this schematic to teach most people about everything from when the patient is breathing 100% on his own, and ultimately the ventilator taking over 100%. And what we see as the course of the disease continues, the patient could very well end up going into respiratory failure and requiring to be intubated. And once intubated, the hopes is that the patient is ultimately extubated and fully recovers. But we do know that quite a long time can happen from this time course of the disease, and also on the ventilator. The primary way that coronavirus affects, again, the person at the level of the lung is through its affectation of the alveolar sac and the alveolar membrane, causing through inflammation, hypoxia, desaturation of the vascular system insofar as to preventing the absorption of oxygen, and then leading to hypoxemia that can ultimately, again, to the death of the person. Now, we do know that it is not just the coronavirus that is playing a major role in this type of disease process, and essentially the way that the person dies is essentially through drowning. It's essentially through copious amounts of secretions and fluid accumulating the alveolar space, along with the capillary block, secondary to all the inflammation that happens, and then the patient can ultimately require intubation and or not recover at all. Now, when we deal with a person who ends up going into respiratory failure, either because of the severe hypoxemia, the increase of what we call work of breathing, the increased inability to not oxygenate, the person would then go into respiratory failure and require some type of mechanical ventilation. Initially, what we try to do is help the patient with non-invasive mechanical ventilation, positive pressure ventilation. It can be everything from BiPAP or CPAP machines. And then ultimately, if the patient does not do well, we're required to undergo endotracheal intubation and then be placed on a mechanical ventilator. But as Dr. Altai was mentioning before, there is a whole host of immune responses and immune stimulation that we call cytokine surges from the infection of coronavirus that can lead to hypercoagulability, that can lead to essentially a severe affectation of the endothelium that will lead ultimately to microthrombi, macrothrombi, and essentially ultimately to hypoxia, either because of the membrane inflammation at the alveolar membrane preventing oxygenation, to blood obstruction from the thrombus that can go in the form of pulmonary emboli and or microthrombi, multiple thrombi, either at the level of the alveolar circulation itself, or if not regionally in local organs, microthrombi that cause ischemia at the level of the organ, thus causing major multi-system organ failures. But when we look at, we are trying to help the patient through mechanical ventilation. But as we all know, sometimes we do harm with some of the treatment modalities that we offer the patient. And the key component here that we're going to speak today about very briefly is mechanical ventilation. And when we look at mechanical ventilation, harm can be done to the patient besides what the coronavirus is doing. Harm can be done either by the direct biochemical injury of the mechanical ventilation, be it that because of the cytokine surge, it predisposes to even more stretching and damage from the ventilator and then worsening of the cytokine surge. It can also predispose the patient to bacterial infections that we will discuss more in details. And these biochemical injuries can then translocate into distal organs, causing, again, multi-system organ failure. The biophysical injury is the shear mechanics of ventilation, which we are going to go over. It's the shear forces, the overdistension, the cyclic stretching in and out, the intrathoracic pressure shifts that can cause permeability issues and also affect the cardiac output and perfusion of the organs as a result of a biophysical injury that we see at times with the mechanical ventilator. When we look again at the different ways in which we look at a person that ends up going into ventilatory support, what we've noticed in coronavirus, like most other ARDS patients, but more so in the coronavirus, we see that there is what we call a heterogeneous acute lung inflammation. What does that mean? That means that there are multiple areas of the lung in which there is severe inflammation, fluid accumulation, edema, and then there are other parts of the lung that do not. So we have, instead of having a very diffuse process of ARDS, we have spotty, we have patches of ARDS. We call this heterogeneous acute lung inflammation. The importance of this is when these types of patients go on a ventilator, when we push the air, because it is positive pressure ventilation, when we push the air into the patient, there will be some parts of the lungs that will get good ventilation, some parts that will not get good ventilations, and then there are these transitional areas that we call transition areas of lung inflammation that are actually some of the areas that will can very well cause more damage because they are not responding very well to the ventilation. Now, just to briefly go over the definition of ARDS, we have what's called the Berlin definition of ARDS. The coronavirus patients do not necessarily fall 100% within this classification, but they do have enough of the characteristics to fall within the definition of ARDS, ultimately an acute lung injury that leads to severe hypoxia. And then again, when we look into the mechanical ventilation, and specifically in these areas, that's designated by the letter B here. The letter A are the better aerated areas, the letter C is the more consolidated areas, and it is in these areas of B where we can have severe lung damage, overstretching. This is where we also have physical stretching, because as we push the air into the patient, more of the air goes into the better ventilated areas, causing a lot of stretching and damage to the lung at the level of the alveolar unit. And then in the areas where there's more consolidation, we have a lot of shear forces that can cause tremendous damage into the terminal airways and also the alveolar space itself. And when we look at these inspiration and expiration changes in mechanical ventilation, it is these that make it very difficult to ventilate patients. Now, there are a lot of protocols, and I'm not going to go into the detailed protocols, but this is what we as critical care specialists are constantly looking at. We are ventilating better. Yes, I'm here. We are ventilating. Okay. Okay, so what we're doing now is, when we look at the complications of mechanical ventilation, we look into everything from the complications of the intubation processes of the lung injury created by the ventilator, the complications of giving the oxygen to the patient, and also the infectious processes that are caused by the ventilation itself. And we know that because of mechanical ventilations in ARDS patients, we have a whole host of complications that can occur, starting from the ventilator-associated lung injury, the ventilator-associated pneumonia, and a whole host of other things, including pneumothorax, and also the problem of having a patient that requires prolonged ventilation being overly sedated. When we look at the ventilator, we have to look into what we call mechanical power. We are essentially putting the patient on an air pump that pushes air in. All these aspects of this mechanical power, be it the flow, the plateau pressures, the vital capacity, the total lung volume, and the respiratory rate, and the PEEP that's used, all are beneficial to the patient, but can also do harm to the patient if we do not monitor the patient adequately and make minute-by-minute adjustments sometimes. As we said, the mechanical ventilator itself can cause both biochemical problems, stretching the endothelium, causing more cytokines, causing more damage to the endothelial membrane, thus allowing bacteria to go into the systemic system, in other words, developing sepsis, and also the biophysical damage, which is the sheer mechanical forces that are applied to the lungs that can cause disruption, and all of these can ultimately lead to death. Again, when we look at the lungs of somebody who has a severe lung damage and consolidation, the lung is contracted, the lung is condensed, as opposed to somebody who has overinflation as a result of areas of the lung that are not being consolidated but are being weakened by the inflammatory process. And when we look at the mechanisms of airspace injury, again, they can be overexpansion. They can be shear forces because of the consolidation causing airway trauma, and then leads to more fibrosis of these patients. These are just the formulas that we use to calculate when we have these patients on mechanical ventilators. And we know, for example, in the black line, this is a healthy lung. The lungs are like a sponge, and if they are working very well, we would get this nice flow of stretching and aeration. But when the lung becomes fibrotic, because initially when the lung is ARDS, we hope that the ARDS, which is the purple, will resolve, will improve and become the black line. But if the lung continues to get inflamed and there is more fibrosis, the lung will become fibrotic, very stiff. And then we get a severe trauma to the lung, because there will be better areas where there's aeration and there will be consolidation, thus destroying the lung. And then when we talk about a patient on a mechanical ventilator, we talk about barotrauma and volutrauma. They all cause stress and strain. And we look at these things of barotrauma causes severe rupture of the airways, leading to pneumothorax or interstitial pneumonia. We also know that the pathophysiology is the mechanical ventilator itself as a result of the weakened areas of the lung. We do calculations based on what we call the K factor, which is the stress factor that is specific to different animals. And in the human beings, the K equals 13.5. We use this calculation to determine the stress that the lung is being subjected during mechanical ventilation. And we also look that as we're ventilating these patients, we're trying to help them survive, trying to minimize the shear forces, trying to decrease the physical stretching so that we can prevent not just destruction of the lung itself, but also distal organs. Again, the transition area where most of the damage of these patients is if we do not monitor and manage the ventilator appropriately. Again, the areas of transitions where we see alveolar inhomogeneity that causes the severe overstretching and consolidation that can lead to damage to the lung. And as we see that the patients continue, depending on how well or how fast they recover, they can end up developing severe lung damage that is not just lung damage that will cause problems with the ventilation now, but will ultimately also lead to lung damage that will cause problems long term. And when we look at the different techniques, we hear about the prone position, changing the patient every 12 hours so that we can get better ventilation on the top and then at the bottom of the lung when we prone the patient. These are techniques that are being used. Again, we prone the patient and we change the ventilator settings in order to prevent too much damage at one part of the lung over the whole 24-hour period. And we end up getting a lot of problems related to when we look at the flow volumes that we use or the curves that we use on the ventilator. We know that there is what we call dynamic strain and static strain, that we can have damage in both dynamic and static. And static can be tolerated better by dynamic, meaning that when the lung is being inflated by the machine can cause severe damage. We have a lot of information over the last 10 years on how to manage these types of patients, but with the coronavirus patients, we are learning specifically how to handle them with low tidal volumes, high PEEP, proning position, and recruitment efforts to recruit those consolidated airways. We know that if we can manage a patient appropriately...
Just 1 minute.
10 minutes. Yes.
Okay.
Okay, and then we are looking at the lung damage that can occur in these patients and the flow volumes that we look to be able to safely ventilate these patients. When we look also at the short-term and the long-term discussions, we also know that there is lung water content on the inflammation and capillary leaks will make the ventilation much more difficult. We have the protocols for ARDS, the protocols for ventilating 2 patients with the same ventilator. We have also the difficulties of keeping the patient safe and keeping the patient from aspirating and causing other complications because of the ventilation. We know that we have situations where the oxygen itself can cause severe oxygen damage. Oxygen toxicity is of major concern because sometimes we have to give these patients a lot of oxygen. But ultimately, what we're looking for is minimizing all these complications, minimizing the barotrauma, the volutrauma, the oxygen toxicity, in an effort to try to avoid more complications from keeping the patient sick and avoiding prolonged and long-term illness that can be one of the major ones, pulmonary fibrosis. And when we see that, when we see that we can, that the knowledge of the pulmonary mechanics will definitely help us save these patients and prevent them from getting sick. But we also have to address that the management and treatment of ARDS in these types of patients, coronavirus 19, at best can sometimes be a shot in the dark. And we try to minimize and help as much as possible, but we understand that the techniques that we sometimes use can also cause tremendous amount of problems. Thank you very much.
Okay. Thank you so much for amazing information in your lecture.